So this session is being named as a tumor board. However, it appears that it's a mix of a panel discussion and a tumor board. And my esteemed faculty, which I have here on board with me, is Dr. Amita Maheshwari. She's a gynae oncologist and professor and head at Tata Memorial Hospital. Dr. Jaya Ghosh, medical oncologist at the Tata Memorial Hospital. Dr. Santosh Menon, gynae oncopathologist, again at TMH Mumbai. Dr. Somashekhar S P, he's the surgical oncologist, but he has devoted a lot of time in gynae oncology and is a very active member in our association too. Also among the faculty are Professor Dr. Sabera Khatun. She's a gynae oncologist, and Professor Dr. Shirin Akter Begum. She also is a gynae oncologist. So during the inaugural session, Dr. Kamaluddin, secretary, in his opening remarks, deliberated upon conceptualizing by the founder as to why it was called Oncology Club. And this really impressed me. And this was named such to do away with a divide between seniors and juniors in the profession when it came to learning and sharing knowledge. A club is an organization of people with common purpose or interest who meet regularly and take part in shared activities. So with the same ethos in mind, the case today has been prepared by Gynae Onco Fellow Rumana Afroz of NICRH Dhaka, wherein she, on behalf of many, want answers for the best practices in borderline ovarian tumor. I am there to moderate with an extremely knowledgeable faculty with voluminous practice, both national and international. So without further ado, we start. I request the faculty to give short answers so as to keep it interactive and cover the case well and be on time. I hope all our faculty members are on board. So this is a case of borderline ovarian tumor. And yes. Mrs. X, 23-year-old nulliparous lady, attended NICRH in March 2017 with an ultrasound diagnosis of ovarian cyst during her infertility workup. And in the past, when she was 19 years of age, she had a history of left-sided cystectomy in 2013 due to left adnexal cyst. And this was operated upon, and the histopathology that time had come as papillary serous cyst adenoma. So in March 2017, that is the time when where the case presentation starts, a CT scan was done which showed a left adnexal complex mass with solid papillation, tumor marker in the form of CA125, LDH, AFP, beta HCG were all normal. And so she was planned for a laparotomy with frozen section. The following month, after having been worked up, she was taken up for laparotomy with a frozen section in a neighboring country. And this frozen section was reported as benign. And with that frozen section diagnosis, a left-sided cystectomy was done. And in the operative notes, it was also mentioned that an omental biopsy was done. On per-operative assessment, the right ovary and uterus were assessed to be healthy. But the final histopathology report which came, it showed borderline serous ovarian tumor, and the omental tissue was normal. So at this point of time, there is a question to Dr. Santosh Menon. So what is the accuracy of frozen biopsy in detecting borderline ovarian tumor?
Good evening, Dr. Biswas.
Good evening. Yeah. Excellent presentation by you
Thank you.
just a while ago.
Thank you so much. So in our setting, we have looked at the accuracy of frozen section borderline. So in borderline, especially borderline ovarian serous tumor, our accuracy is around 90, 92, 93%. So most of the times we get the whole specimen. And when we look at the specimen, it is cystic, and then there are some papillary excrescences on cut surface, and we have to sample those. So if we make sure that we are sampling the right areas, the papillary areas of the cystic ovarian tumor, I think we would not miss a borderline ovarian tumor. So the accuracy is as high as 90 to 95% for borderline serous tumors. The problem comes with mucinous tumors, borderline mucinous, because sometimes they can be multiloculated cysts with very small populations, and when we take multiple section at final gross, we may find a borderline mucinous. So when borderline serous, accuracy is 90-90%.
Okay, so that's a great accuracy actually, and but what does generally a literature say about the upgradation once suppose it has been diagnosed as on frozen as borderline, and the final pathology many a times we get as a malignant tumor, the other way around, so what percentage of them will be kind of upgraded in the final pathology?
I would say so in generally a nicely cystic structure with small papulations should not get upgraded. It happens when there are multiloculated cysts and you're missing certain areas, and then there are thickened wall areas which we have not sampled at frozen. So I would say about 10-15% of the cases would get upgraded to a low grade serous cancer. What we are talking about borderline is a low grade serous cancer. So I think it should be just about 10% on final histopathology, including the microinvasive foci and the frankly invasive foci.
Okay. So this is a question. This is directed to Professor Sabera Khatun. So, ma'am, what fertility sparing surgery can be offered in cases of borderline ovarian tumors?
Thank you, Dr. Manash Biswas, for asking me the question. There is every possibility of doing fertility sparing surgery for borderline ovarian tumor, because borderline ovarian tumor usually it occurs in the younger women, and fertility sparing surgery in case of unilateral borderline ovarian tumor, it is indicated, clearly indicated, but removing only one adnexa, then doing complete staging is the procedure during fertility sparing surgery. And even in case of bilateral ovarian, borderline ovarian tumor, there is a possibility, there is a chance of doing, keeping the part of the ovary and uterus for fertility preservation. So there is every chance of fertility sparing surgery in case of borderline ovarian tumor. Even in case of invasive type of borderline serous ovarian tumor or micropapillary type of serous ovarian tumor, there is a chance of keeping the fertility spare in case of borderline ovarian tumor, because prognosis is very good, almost 100% in case of stage 1.
So when we are talking about prognosis, Dr. Amita Maheshwari, so what is the prognosis after conservative fertility sparing surgery in borderline ovarian tumors? Dr. Amita.
She's
Dr. Amita.
She's here and she's unmuted.
Dr. Amita, could you please unmute yourself?
She's unmuted, sir.
Dr. Amita? request Dr. Shana to just please call her
Yes, I'm calling.
while we
I'm calling, sir.
yeah. In the meantime, Professor Sabera, could you continue with this particular aspect as to what is the prognosis after conservative fertility sparing surgery in borderline ovarian tumor?
Prognosis is very good in case of borderline ovarian tumor fertility after, but the in case of 15 to 30% cases after the completion of the family, in case of 15 to 20% cases, there may be malignant change. But prognosis is very good. In stage 1, it is 100% 5-year survival, and in stage 2 and 3, it is 87% 5-year survival rate. So prognosis is very good, but after the completion of the fertility family completion, the completion surgery should be done, because there is chance of malignancy, and there is chance of chance of recurrence of the disease, though it is very less. 15%, up to 15% chance of recurrence.
So in general, borderline ovarian tumors carry good prognosis overall, and fertility preservation is associated with higher rate of relapse. So when we are doing fertility preservation, there is a higher rate of relapse. However, most relapses are localized and may be salvaged with surgical treatment, and overall treatment is not compromised. And but what is interesting is that if you are only doing a cystectomy, the recurrence rate is about 25%, which is a lot. So ideally, unless both the ovaries are involved, one should avoid doing a cystectomy. One should go ahead and do a oophorectomy. And if you have done a unilateral scalping oophorectomy, the chance of recurrence is halved. It's only 12.5%. But however, most recurrences are localized and are salvageable. So that's the common thing. Dr. Somashekhar, you are here. So once we have diagnosed this, is restaging necessary if frozen is negative, but final histopathology is borderline? This is a common thing, which can come up.
Somashekhar is not here. Somashekhar sir is not. Amita ma'am is here. Sir, Dr. Amita Maheshwari ma'am is here. Somashekhar.
Okay.
Not here.
Dr. Amita.
Yeah. So.
Yeah. Can you take on this?
Yeah. So I think generally speaking, surgical staging is not required unless there was some poor prognostic factors like presence of micropapillary pattern, or if it was a laparoscopic surgery with spillage, something very commonly seen. And if there is no record on assessment of intraoperative findings. So these are the situation where resurgery, or if markers are elevated in post-operative period, or if there is any doubt of residual disease in post-op evaluation, these will be the indication for doing a resurgery. Otherwise, by and large, a restaging is not recommended if the diagnosis of borderline tumor is made after surgery for presumed benign pathology in a patient where fertility preservation is desired.
So yes, this is the general recommendation, and even the standard recommendation which Berek and Hacker give is also the same.
Right. So continuation of your previous point about cystectomy,
yes.
I agree with you. If it is, if you get intraoperative diagnosis of borderline, and other ovary is normal, the preferred surgical procedure is salpingo-oophorectomy. But if cystectomy has been done, and if the diagnosis of borderline is post-operatively, then I think after having a discussion with the patient, our policy is to keep these patients under close surveillance. So we do not go in again to do salpingo-oophorectomy, because often, that's a very practical scenario we face cystectomy done for benign ovarian cyst and final is borderline.
Yes.
So these are the cases if there is no evidence or nothing suggestive of disease and patient is keen for fertility preservation and there is no micropapillary pattern or other poor prognostic factors. So we won't go in again to remove the remaining ovarian tube.
So once we get a frozen diagnosis of borderline ovarian cancer, Professor Shirin Akter Begum, if you would like to tell us that what is the principle of surgical staging in borderline ovarian cancer? Professor Shirin Akter Begum, are you there with us in the panel?
Shinapa? Shirinapa.
So we have very less time in the for the discussion. So is Professor Shirin Akter Begum there, the panel?
She's not. Yeah.
Dr. Amita.
If we get frozen diagnosis of borderline tumor and in a young patient when fertility preservation is required, we will do other steps of comprehensive surgical staging that would involve a thorough evaluation, cytology collection, and any suspicious lesion biopsy, omentectomy, a careful assessment of opposite adnexa, but routine biopsy is not recommended. So if it's a mucinous tumor, we do appendicectomy. Lymph node, unless enlarged, we do not routinely remove lymph nodes if the frozen diagnosis is borderline tumor, because although there is a 10 to 15% risk of nodal metastasis, but these have not shown to have any impact on survival. So that's our policy. And this, if we follow this protocol, the advantage is even if in final you get invasive, generally that will be a well differentiated kind of tumor. So you have done a comprehensive surgery.
Yes. That is exactly what most of the oncology centers would do. And I at my center also, we do the same thing. And but yes, lymphadenectomy we would not do, and the role is controversial, so we don't do a lymphadenectomy. But rest of the staging, as Dr. Amita mentioned, we do, and especially so if it comes out invasive, so we have done all the basic steps for that.
Yeah, just one point I want to make for general gynecologists, that random biopsy of normal looking ovary is not recommended. So taking random biopsy or bisecting is should not be done.
Yeah, it's an absolute no actually.
Sir,
so this
Rupendu
patient underwent
here. You can.
This?
Sir, Rupendu Shekhar ma'am is here. Somashekhar sir is in family program, so he can attend. Please, we can request Rupendu Shekhar ma'am to attend our session.
Okay. Yes. So so this patient had a tumor board decision of observation, and then she was followed up with ultrasound. So at the same time, she was advised to avoid pregnancy for 1 year.
So I just want to make a point here, Dr. Manash, if you allow me.
Yes, sure.
I think that no conception for 1 year, we do not recommend for borderline tumors. In fact, our recommendation is that they should try for conception as early as possible.
As early as possible. Yes.
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 Yes. Yes. So this is what actually I have tried not to change much of the content of the slide, which Dr. Romana has provided us with. So, however, yes, it is important that we tell the patient to try and conceive as early as possible. So, how to follow up a patient with borderline ovarian tumor? Dr. Jaya, you would be there. Dr. Jaya?
Yes, I'm there, Dr.
Yes.
Manash.
Yes, so borderline ovarian tumors, patient being diagnosed, and so regarding imaging, regarding tumor markers, frequency of visits. So would you just tell us how would we plan a follow-up?
So for borderline tumors, many a times the tumor markers are normal, but nevertheless would do a tumor markers every 3 to 4 months and do an ultrasound apart from, of course, clinical examination every 3 to 4 months for the first 2 years and then 6 monthly.
Okay, so the general follow-up is almost similar to what we
Can
would
I
do in case of
can I just make a
malignant.
point here, Manas, even though
Yeah,
I'm not in
sure,
the
sure. No. You are in the panel.
so no,
So
no, I'm
please,
not.
yeah.
I'll just make a just a small point
We
regarding
want you
imaging.
to be in the panel. Yeah.
No,
Okay.
no, I mean this regarding imaging. No, once a cystectomy has been done on one side, or maybe some kind of thing, oftentimes the patient comes back to you with a cyst on that side, or maybe an ovarian enlargement on the other side, a relative enlargement. So it is very important to know what is the cutoff. When are you going to intervene? And of course, the tumor marker would be normal. So let me have the thoughts of the on this of the other panelists. When would you intervene?
Yeah. So, Dr. Sabera, do you have a point to make? The basically
About
what the query is that a cystectomy has been done in a patient, and now this patient is being followed up with an ultrasound and to see any ovarian enlargement. So sometimes cysts do form again in the ovary which has undergone a cystectomy, or the other ovary is enlarging in size. So what would be the kind of a marker or a cutoff where we would intervene? That's the question which Dr. Rupinder has put forth.
marker here in borderline serous ovarian tumor. This is the case of borderline serous ovarian tumor. In this case, there is in 50% cases there may be raised CA125. So we can do that CA125 for follow-up of the patient. If there is any raised CA125, in that case we can go for surgery.
So,
No,
but
Just
at
to
the
add,
same
if I
time,
may,
in a young woman, CA125 in a young woman, a
But
premenopausal
in
or a young woman
addition,
is hardly doesn't hold much of a significance actually. So it's very difficult to
and
follow up. As such, the CA125 may not be raised. That is one. And the second is that in a young woman, it may not be
but in
significant.
addition to CA125, you have to do the imaging, that is transvaginal sonography. Transvaginal sonography and color flow Doppler study. These can be done, and even CT
So
scanning.
what
can
would be
also
the
be
kind
done.
of, Dr. Amita, any comment
yeah,
as to
so
what would be the size cutoff in which you would intervene?
So I agree with Dr. Rupinder. In fact, generally our policy is not to be in hurry to intervene immediately. Oftentimes we see functional cyst or, corpus luteal cyst coming up in these young patients. CA125, it's not really very this thing. So my personal policy is, if any doubt one, we do MRI and also try to keep them under close surveillance. Even if there is some doubtful thing, instead of intervening immediately, keep them under surveillance, repeat after 3-4 months, and only if there is definite increase or some solid areas or definite evidence of progression or disease, then only intervene. So that's our policy.
So,
And
so
we do
I
basically
quite
the
such
board
agree
of,
with this, because this is such a gray area. If I can just take 30 seconds, we had one such patient. We had kept her on surveillance, and just like Amita said, watching her closely. But then, to our horror, in less than 3 months, she actually had we got a CT scan of the whole abdomen done, and she had deposits in the omentum.
so it can be, Dr.
And then
Rupinder.
when we finally went in and did a surgery, those were invasive deposits, though they were very small. But I think this sort of a thing can easily be missed if we just.
So
Yes.
that particular case was an odd one out, and we have odd ones always. But
Yeah.
usually borderline tumors, we can wait and watch and go about it slowly. But yes, this can happen.
But frequent
happen.
follow-up should be done.
Yeah. So
I think
very
in
close
doubt,
surveillance. The dictum should be a very close surveillance,
Close
follow up, and educating the patient the importance of follow up.
Right.
Yes.
And MRI is a good.
Yes, so change the modality of imaging.
And one
also
more
do
point.
not hesitate to intervene. If you have to, do not hesitate. Better to have a negative laparotomy than to have,
The only concern is these are young, infertile
Yes.
women.
Yes.
If we
that is a huge,
intervene,
that's a huge problem there. That's right.
we have many
So-
cases otherwise, who had no malignancy and we have intervened. So
Yes.
one more point, Dr. Manas, if I may make quickly, all these patients, I think we should always do baseline AMH level. And
Yeah.
which we have
Oh,
started doing
excellent.
routinely nowadays, but so everybody.
Amita, if I can say this, Amita, you had made this point in a one of these kind of webs long time back, maybe a year back, and since that time, no, we have been doing this. I followed that, and I thought that that is so useful, because not only do we have a baseline AMH value, we are also able to advise the patient as to what is the what is the prognosis in leaving a surgery and fertility preservation and all that.
Absolutely.
Before they start spending a lot of money, you have a very low AMH. There's just no point in doing conservative surgery where you are in doubt.
Right, and some of these borderline tumors actually have very compromised ovarian function at baseline.
Yes, absolutely. Yeah, quite right.
So transabdominal, transvaginal ultrasound are optimal technique for surveillance for a treated borderline ovarian tumor, and CA-125, as we have discussed, is a limited value for follow-up. And follow-up of the patient with no evidence of disease is same as those for malignant ovarian tumor, but less frequently. If contralateral ovary has been retained, it should be followed up by transvaginal sonography at least annually. So, Dr. Jaya, is there a role of adjuvant chemotherapy in borderline ovarian tumor, especially when we are considering a differential diagnosis, low-grade serous or a high-grade serous, and a role of any hormonal therapy?
No, so presently for borderline tumors, there is really no role for any adjuvant chemotherapy. So sometimes, we have a borderline with an invasive implant. Now, borderline with an invasive implant is what is classified as low-grade serous, and an omental deposit technically makes it stage 3. So now, there are two different situations in this scenario. I think, one is where, patient has extensive omental disease, omental invasive implants. There, I don't think there is any doubt that this patient with invasive implants needs, that is a low-grade serous, which is stage 3, needs an adjuvant chemotherapy. I think the doubt comes in when the whole thing is borderline and we have a single focus of invasive implant, 2 centimeter in that entire area. There, the benefit of adjuvant chemotherapy is probably where it is debatable. So that is what, and that is when we discussed with a pathologist, Dr. Santosh is here, just a few days back. We had such a patient where it was a low borderline in the primary, and there were a couple of focus in the omentum, one of which was invasive. So that is what.
Anything about the hormonal therapy? Have you treated patients with
no, if it is a
low grade?
No, if it is a borderline, nothing, observation only. If it is a low grade serous, and if it is a stage 1 disease, I would really not put them on adjuvant hormone. But stage 3 disease, advanced stage low grade serous, after adjuvant chemo as maintenance, we can put them on adjuvant hormone therapy, and that has shown a benefit in retrospective series.
Yeah.
Just a point, and Santosh can add. We should always ask for ER/PR in these patients with borderline and low grade kind of patients.
Yeah, ER/PR is routinely done for low grade and borderline patients.
So this is exactly what we just said. So this patient was, after that, she didn't come for a regular follow-up. And this patient conceived in 2019 and delivered a male baby in November 2019 through a cesarean section. Her ultrasound during routine antenatal care and peroperative finding of cesarean section had no adnexal pathology. So 6 months after delivery, a right adnexal complex mass was detected on TVS. This was about 8 into 9 centimeter. So the question is, in case of a relapse, after conservative surgery in borderline ovarian tumor, can second fertility sparing surgery be done? Dr. Amita?
Yes, after careful counseling, one can contemplate second fertility sparing surgery. Again, I would say AMH level should be repeated, and if it is decent, then one can. Of course, final call will be intraoperative, whether adequate ovarian tissue, normal ovarian tissue is possible, preservation possible or not. But yes, it can be done. Theoretically, yes, it's possible to do.
Yeah. So most of the literature does say that conservative surgery can be again redone in cases of borderline ovarian tumors. So when BOT recurs in a spared ovary after fertility sparing surgery, patient desires to preserve fertility, a second conservative surgery can be considered. So then this patient, when she was, further imaging was done, a lobulated complex mass was seen in right adnexa. There was no ascites, no lymphadenopathy. CA-125 was 178, and the other markers were essentially normal, slightly raised. After thorough evaluation and counseling, this patient underwent a laparotomy followed by frozen biopsy in May 2020. And the findings were uterus, left ovary was healthy, a 12 into 8 centimeter mass in right ovary, capsule smooth intact, no ascitic fluid, no metastatic deposit. One of those cases, Dr. Rupendra, where a mass has grown very rapidly. The frozen report which came per op was positive for malignancy. A total abdominal hysterectomy with BSO with complete surgical staging was done, which included peritoneal washings, infracolic omentectomy, right-sided pelvic and para-aortic lymphadenectomy was done. Now, histopath of this patient this time revealed high-grade papillary serous cyst adenocarcinoma, capsule not involved, and the surgico-pathological staging was stage 1A. So this is a quick one-liner answers I want. This is from Dr. Santosh Menon. So can a borderline ovarian tumor recur as a high-grade carcinoma, and is IHC needed to confirm?
Dr. Manas, I think this is a difficult question, but usually borderline ovarian tumors give rise to low-grade serous carcinoma, not high-grade serous carcinoma. There have been few cases, especially from US, MD Anderson and MSKCC, where low-grade serous carcinomas, known cases over certain years, very, very few, a handful of cases of low-grade serous have been transformed into high-grade. But a borderline serous tumor, which has been borderline all throughout, suddenly presenting as a high-grade serous carcinoma seems very, very unlikely. So my point is, this can still be a low-grade serous carcinoma that can present as a disseminated thing, and it can, although the growth is very fast in this case also. So I would really doubt it. So I would definitely do a P53 to confirm this.
Yes.
Would
No,
you
it was
want
not
to see the
disseminated
previous
also,
slides?
very
Would you want
limited
to
to
have a
one
relook
ovary.
at the previous slides? It might not have been a borderline at all.
But the history is very prolonged, ma'am. For a high grade, it is very prolonged history. So I think this might be a low grade serous carcinoma, and P53 is needed for this.
And Dr. Sabera Khatun, this is in stage 1A high-grade ovarian cancer, can conservative surgery be still considered if a patient wishes to conserve fertility?
High-grade serous ovarian cancer stage 1, yes, conservative surgery can be done.
So, however, this case was different. In this case
was different.
TH and BSO was done.
But
so,
this is the transformation of the borderline ovarian tumor to high-grade serous ovarian cancer. And I think she has one child. The unchild in case of malignant ovarian tumor can be considered as a family is complete.
Yes.
So she can have,
Yeah.
she does not need, in this case, she does not need any conservative surgery. Definitive surgery is the treatment for this patient. But in case of isolated.
So I'd like to go back to the previous point, and if Dr. Romana is there hearing our session. Dr. Romana, are you there?
Romana.
So, or Dr.
Yes,
Shana,
yes,
if you have been associated with this case, so was
Yes,
it considered a re-look at the biopsy, whether it was a low-grade carcinoma?
No, sir.
Because a high-grade carcinoma is a little rare. Was it discussed in your forum for this particular case? Just offhand, I'm asking because this is a very, very important point. This is very rare to see a high-grade change from a, a very, this case actually really presented as a borderline because the history is so prolonged.
Sir, it was at first, I'm telling in brief that it was at first, it was diagnosed in Bangladesh. It was the serous adenoma. Then it was operated in CMC, and there it was the paroperative frozen section. It was just the no malignancy and histopathology, borderline tumor, and after conception, it was diagnosed at the high-grade serous carcinoma stage 1A. What is your question, sir? Now?
No. Basically, was there a relook of the biopsy, relook of the histopathology, which showed as
That is
high
review
grade
of
was done?
slide. Review of
Relook
slide.
histopathology,
Review of
which one,
slide.
sir? Sir, which one? Third time surgery?
Third time, the high grade carcinoma.
High grade
High grade, no,
Because
carcinoma.
very
no.
rare for a change
No.
of a
No, sir.
borderline to a high grade.
No,
It's usually
it is opposite ovary, sir. It was in opposite ovary.
Still good.
Rumana?
even that, even though.
Yes, sir. No, we didn't do that. We
Okay.
didn't.
All right. So let's go over to the another question is, Dr. Jaya, is adjuvant therapy indicated in this particular case?
No, so of course, as was rightly mentioned, that we would confirm whether it is high grade or not, and as it is very unusual. However, if it is one of the very rare cases where it is a high grade, so since it is a high grade carcinoma, even though it is 1A, it would merit 6 cycles of adjuvant chemo, same paclitaxel and carboplatin.
Yes. Dr. Rupinder, so can you give us a comment on BRCA testing? When would you advise for this particular case? I think Dr. Rupinder made her comment and I think she's not there. Dr. Amita, what would be your advice for a BRCA testing for this young patient?
Yes, Yani, if high grade is confirmed, we'll advise her genetic testing, and both for BRCA and early from any P53 mutation, because she's just 24, 25. So,
Sorry, I was a bit away. I agree with Amita. Yeah.
Yes.
Okay.
I also agree.
Rumana was
Dr.
muted. Now Dr. Rumana is unmuted.
Sir, am I audible now?
Yes. Okay. You
Yeah.
stay.
So, Dr. Jaya, anything to add regarding the BRCA testing?
No, if it is high grade, of course, then, and of course, on some low grade also, we would consider for BRCA testing, not so much for borderline, yes.
Okay. So a tumor board decision was taken for this case and 6-cycle paclitaxel and carboplatin was completed in October 2020. That's exactly what Dr. Jaya has said, that this patient being high grade warrants chemotherapy. So after completion of chemotherapy, CA125 was 65 international units per ml and ultrasound was essentially normal. Patient was under follow-up till March 2021. After that, she did not come as she was asymptomatic. Then in December 2021, patient, after 14 months of completion of adjuvant therapy, patient presented with recurrence. Now, so at this juncture, this could be commented by Dr. Sabera Khatun, that what imaging modality would you prefer to assess the amount of disease and operability, whether it should be PET CT, MRI, CT? And what would you do at your center?
I think this is in a very short period she has recurrence, so she should be assessed by PET scanning.
All right. Okay. So actually, we have finished about the borderline ovarian tumor. I'd like to keep it very short, otherwise it would be entail another huge panel discussion. So, Dr. Amita, can you give a comment as to how would you assess this patient, and whether this patient should be for secondary cytoreductive surgery or she should be for chemotherapy?
Yeah.
I will tell you the findings which I found out from Dr. Romana.
Right.
She
Yeah.
said there were 3 masses. One was a big mass which had facial planes well preserved. The second deposit was adherent to the rectum at one point, and there was a third deposit in the peritoneal region, peritoneal abdominal cavity, but there were 3 deposits. There was no ascites.
Okay.
And there were no
So-
diaphragmatic deposits, no other disease elsewhere.
Right. So considering her young age, she's in ECOG group 0, I guess. She's in fit condition. There is no ascites. There is disease which is, as per description, surgically resectable to R0 status. And there is no ascites. I think I would consider a secondary cytoreductive surgery in this case. She's a platinum sensitive, 14 months since her last treatment.
Dr. Sabera, what is your comment regarding
Yes,
secondary cytoreductive or chemotherapy?
I also suggest secondary cytoreductive surgery for this patient because she is young patient.
Okay. And Dr. Rupinder, are you there?
Likewise, yeah, likewise.
Oh, chemo definitely, but cytoreductive surgery followed by chemotherapy. She is someone who may benefit.
So she is actually a good candidate for a secondary
Candidate for
cytoreductive.
surgery.
Yeah.
Yes.
So here is a very important question. Actually, this was put forth by by Dr. Romana, who had sent me this case. So they wanted to know that should HIPEC be done along with secondary cytoreductive surgery in this case. So first, Dr. Jaya, what is your comment on this?
So for this patient who initially had borderline transformed to high grade, and now I'm really not sure about the benefit of HIPEC in her.
Okay. Dr. Rupinder, since Dr. Soma is not here, Dr. Rupinder.
No, I would definitely want to do HIPEC for her. Especially if I'm able to do a complete cytoreductive surgery for her and achieve a CC0, then yes, I think.
So this, we are going to achieve a CC0 in this particular case with the type of imaging we are seeing.
I don't know. I don't know. Not
okay.
necessarily. Not
so if you
when you open this patient,
if you achieve a CC0, would you be doing a HIPEC? And what is the evidence that would it be beneficial for this lady?
I see, if you are talking in terms of evidence and in terms of this, so far HIPEC has only been FDA approved for your IDS, for your interval debulking surgery. And I don't think we have any concrete data to prove this, that if we give HIPEC for in a recurrent setting, the patient will benefit largely. But I still do think I might counsel the patient and might go ahead because she's so young. I think we should try everything in our armamentarium to prolong her life, which is I think doubtful because slowly the interval between recurrence and treatment is certainly getting shortened.
Dr. Sabera Khatun.
Yes, I think that depends upon whether there is any peritoneal extensive.
No, I am asking that if you achieve a CC0, would you consider HIPEC to be done along with this in this particular case?
No.
And Dr. Amita, what is your comment on this?
Intuitively, one may say, yes, we want to do, but currently there is no evidence to suggest that HIPEC is beneficial in this setting. Although I must say that there is actually no good trial either ways. There is only one small phase 2 study from MSK less than 198, which I showed during my presentation also. Where they used carboplatin for HIPEC, and this study although showed that it is, tolerance wise there is no problem. Carboplatin in HIPEC was all right, but there was no survival benefit.
Yes.
So whatever data we have, it doesn't really support. Having said that, we have actually got very limited data, and this is something we need more evidence to accept or refuse. And we won't do it at our center.
So I think this is the general consensus. In fact, all the faculty, whosoever I asked today, has given the same answer, that some centers probably may be carrying out and thinking that HIPEC is, is a kind of a treatment along with a secondary cytoreductive surgery. Many centers were doing it. But there are more and more evidence coming back that is not beneficial. A good cytoreductive surgery where we achieve a CC0 would all what is required. So the tumor board decision which was taken for this patient in the NIRH was that this patient should undergo a secondary cytoreductive surgery. However, because this was going to be the fourth laparotomy in this particular case, the patient had reservations about it. And also what I found out from Dr. Rumana was that she was told that there would be chances of stoma, which then made her go against the decision, against getting a laparotomy done. And so therefore, then the tumor board said that the second option is chemotherapy. So this patient right now is undergoing chemotherapy with paclitaxel and carboplatin, and she has received first cycle of therapy. So the only point I would like to make here is that it is how you tell about the stoma to the patient. I feel that this patient was a very good candidate for a secondary cytoreductive surgery, which all the faculty here have agreed upon. And it is the way we counsel about to a patient about the stoma, whether it can make her very fearful and totally go against stoma. Most of the cases, the stoma is not required. LAR can be done, and stoma is not required.
Manash,
so thank you.
Manash,
Yes.
sorry.